Hmm. Okay.
Good evening, everyone, and welcome. Just for people who don't know who I am, my name's Antoinette Christie. I'm the founder and chairperson of M.E Support Northern Ireland. M.E Support was founded following my son's diagnosis of ME at the age of 11, 20 years ago. David is now one of our trustees, and you may hear from him a wee bit later on. This event tonight is part of a series of our events that we're hosting for ME awareness. We are currently engaging with local politicians in Northern Ireland and dozens of charities and campaign groups. We will be sending out emails to all of you tonight for all the attendees to let you know what's happening. If you're based in Northern Ireland, we would really encourage us all to reach out to us for more information. I'm not going to keep you on too long, just in case there's any technical issues. I just want to apologise in advance because we've never done this before. So we're hoping everything will go smoothly. I don't want to delay any further, so I'm going to introduce you to our guest speaker who will speak and answer some questions with you all on ME. So please welcome Dr. Nigel Speight.
Hello, pleased to meet you. It's a bit unnatural talking to a blank screen and to know that there are lots of faces out there, and it would be much nicer if we could meet face to face, but welcome. And I'll say a bit more about myself before I start talking about the things I was going to mention. I've had a 30-year interest in ME. I'm a general paediatrician, worked in Durham, and I became interested in it quite early on when a girl in a wheelchair came to my clinic and announced she had ME. And then I learned from a lot of the early pioneers like Betty Dowsett and Alan Franklin and David Lewis. And I've been kind of immersed in ME ever since. And I'm officially a medical advisor for quite a lot of charities, the English and Welsh ME Association, Times Trust, 25% group, which includes adults. And in recent years, I've developed a major interest in very severe ME, of which there have been some tragic cases in England in the last few years, including deaths. Things got better for a few years and then they got worse again. And currently I'm getting 1 or 2 new cases a week, looking for help with diagnosis. And about 10, 15 years ago, I had lots of paediatric allies, all of whom believed in ME and saw cases all over England. But it's become a bit attenuated since most of those people retired or died. And I do feel that I'm ploughing a bit of a lone furrow sometimes. Of course, I don't see the cases who are already perfectly happy with their local paediatricians. Got quite an interest in both Northern and mainland Ireland. I've been to the north a few times and lectured as well. And last year I did a tour of Ireland, speaking to their charities and their support groups. And it's very interesting comparing the situation between the two. And I kind of joked beforehand to the organisers that it seems that doctors in Ireland are nicer to their ME patients than NHS doctors in Northern Ireland and mainland UK. And I joked that it's maybe because they pay them and it's that persuades them to keep their patients happy. It cancels out a bit, and there's some advantages in being in mainland UK and in Northern Ireland, and I'm going to talk about this at some length. The biggest advantage for people in England, Scotland, Northern Ireland, Wales, is that we have, in 2021, we had some absolutely marvellous, nice guidelines. I know they don't necessarily apply the letter of the law in the devolved countries, but they're still a very powerful weapon for the ME community. I think most of you will have heard of them. Most of you will know that in 2007, NICE guidelines unfortunately endorsed graded exercise and graded exercise therapy, GET, and CBT as treatments for ME, and that led to enormous problems because it's basically an implicit support of the psychosocial hypothesis that ME is due to faulty illness beliefs and deconditioning. They finally, very methodically, studied all the research for graded exercise in CBT and have virtually dismissed it as inadequate and flawed in extremity, and they have completely withdrawn those recommendations. And that means that implicitly they have withdrawn their support for the psychosocial hypothesis. I know people call it the biopsychosocial hypothesis, or I call it the psychosocial heresy. The trouble is the people who believe in it always forget the bio anyway. But NICE guidelines themselves do actually stress in their first introductory sentences that this is a genuine multi-system medical illness. In other words, it is not psychological, and this should be the last nail in the coffin of the psychosocial hypothesis. So that's very, very good news. NICE guidelines don't just stop there. They then go on to give extremely simplified guidance on how to diagnose. I'm going to say in a few minutes how important diagnosis is. And if you just follow the NICE guidelines on diagnosis, you could teach a 12-year-old boy scout to diagnose ME in half an hour. So people who go around saying, oh, I couldn't possibly diagnose ME because I haven't been trained. If you want to educate your GP, just show him NICE guidelines and the diagnostic guide. So gradually, I think we want to work from the bottom up and persuade GPs to get off the fence and to be brave enough to start diagnosing ME, especially in Northern Ireland, I believe, where they don't have anyone else to refer to.
Can I ask, Doctor, just to underline that point, it's your view that GPs should be able to diagnose most cases of ME through the NICE guidelines themselves?
I personally believe it. They diagnose lots of other things. They seem to have this phobia for committing themselves. My own general practice in Durham, which is an absolutely excellent one, are still at the stage where they say, I mean, this excellent GP said, oh, there's no one in this practice will diagnose ME for fear of litigation. It's absolutely mad. No, if they're a bit scared, they can it's a provisional diagnosis. And there's lots of guidelines on what simple investigations they should do. And it is quite important. GPs are so important because early diagnosis and early advice avoids that terrible thing where either the patient or their advisors lead them to overexertion and thereby worsening their prognosis. So, and the NICE guidelines again say you can diagnose ME in the first 6 to 12 weeks of onset, and acute onset ME should be diagnosed really early. So NICE is marvelous for all those reasons.
Sorry, Nigel, do you think because basically in Northern Ireland there's nowhere for the GPs to send the patients if they do diagnose them? There's nowhere for them to go, but they're actually not even diagnosing patients.
Here I'm at odds with quite a lot of the charities. We've been sitting on a committee working with NHS England or whatever it now is for a delivery plan for and the charities keep saying they want specialist services, they want experts, they want centres of excellence. And I'd say the exact opposite. I think we should be aiming at the bottom and building it up from the bottom. And I've always said a good GP is better than a bad specialist.
100%, I agree with that.
And the one thing we have pushed, and the charities have agreed to this, that in England, we're hoping they come out with a recommendation that every general practice elects one of their members to take an interest in ME and offer and seek a little bit of training and gain confidence in it. And the same for every DGH, that there should be a named physician with an interest. And last week, our committee suggested paying a financial incentive of £500 a year. And I said, that's probably best not to talk about money, just make it part of their duty that one of them does this, just like there'll be a person for safeguarding and a person for epilepsy and a person for diabetes. So I believe in the bottom-up approach. I do see some excellent GPs handling average cases, and they average severe cases, and they don't actually need to be seen by a specialist because there isn't all that much you could do. I keep trying to say, it isn't rocket science. Diagnosing and managing ME is not rocket science. And a good GP can manage nearly most of the cases who aren't the very, very severe challenging case. And that needs a lot of people all pulling their weight. But similarly, if they have a nice DGH consultant who's also been named, they should be referring to him and being supported, and then they come back and the GP is still terribly important. I think many years ago, I had a case in Northern Ireland where the child was evicted from the pediatric ward on her 16th birthday. And I was called across to try to get an adult physician to take an interest, and I failed. And a very broad-shouldered GP handled probably the most severe case in Northern Ireland for the next 7 years, very, very nobly, and did a great job, and probably a better job than the specialist might have done. And above all, you want people who are willing to visit the severe cases. So that's nice guidelines. So in some ways, we're better off than Ireland itself, because when I was there, they don't have any guidelines. And again, I was saying, well, in that case, adopt British NICE guidelines provisionally as a framework to be going on with. I'd like to go back to the importance of diagnosis. This is probably the commonest thing I'm being asked for. You won't believe it, but I've had a request from Alberta in Canada and Algeria in the last 3 months because they couldn't find a doctor in that state or that country who understood or knew about ME or who could diagnose it. And I diagnose people by Zoom consultations because, in fact, the history is the most important thing. So Osler used to say there are 3 principles in medicine: diagnosis, diagnosis, and diagnosis. We've moved on a bit since there because we do have some treatments, but we seem to have developed a whole lot of doctors who don't diagnose. They can write long letters back to the GP. They don't actually put a diagnosis at the head of it. And then they investigate, and then they talk of some sort of rehabilitation, but they've never made a diagnosis. So diagnosis is vitally important for ME. In children, it's vitally important as a protection from pressures and inappropriate accusations against families. And this is a major issue. So diagnosis is important, and not just for protection, but also for access to benefits and special allowances. I've talked about the good news from NICE guidelines. There's still some bad news in British paediatrics, and this emanates from, I'm ashamed to say, from my own college, who in 2011 adopted, for, I personally think, zero logic, adopted an extended definition of fabricated and induced illness. This was on the recommendations of a child psychiatrist. I think you will probably all have heard of this. I'm sure fabricated and induced illness, FII, is alive and kicking in Northern Ireland. It certainly is all over the rest of the UK. There have been workshops all over the place, and school nurses and A&E consultants and GPs are accusing families of FII at the drop of a hat. I recently had a case where the A&E consultant referred them straight to social services because the mother brought her child to A&E in a wheelchair. And the child psychiatrist who does these workshops says she has a thing about wheelchairs. But the extended definition, FII used to be Munchausen by proxy. Munchausen by proxy is real. It's extremely nasty. It's extremely peculiar. Mothers putting blood in their children's urine to fake the doctors. It's as rare as hen's teeth, true Munchausen by proxy. But by extending the definition, they have increased the potential incidence 1,000-fold. It's a major empire. And the new definition includes, listen for it, medically unexplained symptoms, which means everyone's food allergy, autism, or ME, or long COVID is in danger. And the other is perplexing presentations. So this umbrella has gone over this enormous thing. And as I say, if you look at a bell curve of parenting, and there's good enough parents and super parents and not good enough parents, they've actually trapped a whole lot of super parents who are doing the best for their children. I've been negotiating with our college privately as much as I can over the last 6 months, and they are actually due to review it. But until they've reviewed it, I think it remains a menace and has led to so many of the cases I have to get involved in. The social services in Britain have actually spotted what's going on because they get all these referrals, and they have done surveys. And Leeds, a place in Leeds, did a survey of FII referrals, and they found that 80% of them led to no action, and probably the remaining about 15% had a bit of action and then eventually closed the case. And in addition, most ominously, 50% followed a complaint from a family against a professional, and the referral to social services was therefore a form of revenge. I recently had a case where the paediatrician accused the child of being too fat and lazy. He wasn't. The mother put in a complaint and was referred to social services. Social services gobbled it up and enjoyed making a case out of it. They ran with it for a year, put the child on the protection register, had fortnightly visits from social services, asked the mothers to engage, and eventually a sane social worker came on the case, said the emperor had no clothes, and that they've closed the case. No action, didn't even need child in need. That was a case of long COVID ME.
Do you have any view, Doctor, on where this hostility towards some very sick children comes from within medical profession or social services?
Where? I always joke that those doctors God wishes to drive mad, he confronts them with a case of ME. And if that fails, he confronts them with a case of severe ME, and that definitely works. So there's something about ME that drives doctors mad. You know the story about the Australian boy who's son of a doctor, and he developed ME. And over the next year, he was taken to all the experts in Australia. And they said at the end of the year, you must have found out a lot from having seen all these clever doctors. He said, not much. They don't understand it. But there's one thing I've noticed. It induces an acute psychological disturbance in doctors confronted with it.
Mm-hmm.
So I don't know why it drives doctors mad. I think it's because they're not taught it. They're just subject to Chinese whispers. It's not properly covered in medical textbooks. Kumar and Clark, the Bible of medicine, includes it under psychiatry. So it's been taught not at all or wrongly. And therefore they think it's mad. But
and just on that,
I often have to apologize for our profession.
Someone has asked the question, is there anything that sort of the wider community here can do to convince the Royal College of Paediatricians to change and sort of be more open to that?
Chronologically, the people who've done the research, the social workers, the actual British Association of Social Workers put in a direct frontal attack on our college, which sadly and predictably led to a defensive response. So I wouldn't suggest anything too forthright, but I think expressing a concern that this, especially if you in your own experience have seen paediatricians making inappropriate referrals, you could add to the ongoing discussion. I should mention that neurologists, as you know, the World Health said ME is neurological, and ever since neurologists have been running away from it as fast as they can. They hate it. They have invented their own version of something that leads to these FII type umbrella things, and that's functional neurological disease. And for the life of me, I haven't a clue what it means.
Mm-hmm.
I think it's alive and well in Northern Ireland, isn't it? Functional neurological disease, FND.
Yeah.
Say it. How are we doing for time? Oh, we've still got some time. I'd
Just
say
a wee question here. There's another wee question here has just come in. If ME goes hand in hand with POTS and MCAS, why do our kids have to battle to see all sorts of different medical specialists to get help?
Oh,
each giving them all conflicted advice.
I see kids every day who've gone to they actually find it easier to get the other diagnoses than the ME. They go to a POTS specialist and he says, yes, you've got POTS, but I can't possibly say whether or not you've got ME. It's specialization. It's crazy. And it's all this form of retreating away from committing yourself to a diagnosis of ME. I mean, all we do is make diagnoses on the balance of probability. I just, so this sounds like ME enough, but you follow them up. If you follow up your patients, and if you've made a mistake, I've seen over 2,000 cases of children with ME around the country and the world, and I've made 2 genuine mistakes out of those 2,000. One turned out to have very severe chronic Lyme disease, and the other, at a very early stage, I'd suggested the diagnosis on the first meeting. And when the mother came back, she said, well, actually, I think it could be narcolepsy. And this was a boy who was falling asleep at school. And she was right. And we took the diagnosis away. So there's no harm in making a provisional diagnosis, giving the right advice about not going great at exercise and stop going to the gym for a bit. And then keep an open mind. Do the tests, whatever.
There's a question there is, why won't my pediatrician call it ME, only CFS? Do you see any sort of distinction?
Yeah, I always remember, those of you who are old enough will remember the arguments about nuclear disarmament. And there were those who said they believed in unilateral nuclear disarmament, that we should give up our nuclear weapons, and those who said, no, 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 we should do it multilaterally. And the great peace campaigner Bruce Kent said, the only difference between people who, the multilateralists and the unilateralists, is the unilateralists believe in what they're saying. In other words, they believe in unilateral, and the multilateralists don't actually do anything. It's the same with CFS. I find the willingness to label it is terribly important. Coming back to NICE, what has NICE done its report on? It's done it on ME CFS. In 2007, it was CFS ME. I argued in 2007, can't you call it, with the CMO's report said, can't you call it ME CFS? They said, oh, it's more than a life's worth. The psychiatrist will get at me. But I think CFS should be consigned to the dustbin of history. We all know the deficiencies of it, that some of the definitions included cases who were depressed and didn't have post-exertional malaise. And again, NICE have said post-exertional malaise is the cardinal symptom. That's the one thing, if you're training your 12-year-old Boy Scout or your GP to diagnose it, you have to teach them how to ask the right questions for post-exertional malaise. You won't believe it. Last week, I saw a case in an alleged centre of excellence where the child is bedridden and in severe pain and clearly has severe ME. And a member of a multidisciplinary team who had not seen the child said, no, we can't say that she's got chronic fatigue syndrome because she doesn't complain of fatigue. She's got chronic regional pain syndrome and needs physiotherapy. So diagnosis and calling it ME is terrible. You all
There's
know.
a few other questions there from a few people are asking.
Can I just finish on the labelling and come back?
Oh, sorry about that.
There's that beautiful statement that was said at the CMO's report that abolishing the term ME and replacing it with chronic fatigue syndrome would be as unhelpful to the patient community as it would be to abolish the term Alzheimer's and replace it with chronic forgetfulness syndrome, because we all get a bit forgetful sometimes. Sorry, carry on.
As there was just a few people asked, is there any particular reason why GPs ignored the NICE guidelines? And another person asked, do you know when the guidelines are updated or changed?
Well, I don't think they'll be updated for another 15 years.
Right, so it's long term.
If some new treatments become, if some treatments, science advances slowly and there's a long gap. But it was the charities who agitated to get NICE guidelines reviewed, and that was their work that got the chief medical officer to persuade NICE to do it. And I don't think we want them to be reviewed again too soon, unless some treatments come along. But it's very good on pacing. It has a lovely phrase: the patient should attempt to stay within their own energy envelope.
Yeah, very good. Thank
They
you.
didn't call it pacing, but it is pacing.
Yeah.
Yeah.
And they don't pretend it's therapeutic, that it's curative.
Okay. And just for some people who asked the other question, why are GPs ignoring the NICE guidelines when you obviously can tell us they're so good now, the updates?
I think it's because of their education. We've reared so many doctors that they can't believe in things if there isn't a test for it or something. The lovely physician,
Just on the
Abraham,
back of that, Nigel, but if a GP knows the person for many, many years and has seen a significant change in that person, surely they have to be listening to them.
I agree. I mean, there are some very good GPs. I quite often find a GP who's perfectly happy to diagnose it and wants advice, and we don't hear about those cases. But they're not taught about it. I mean, there was a GP in Devon who, when this patient advocate admitted that she had ME in his surgery, stood up, towered over her and said, "Madam, I've been a doctor for 12 years, and I can assure you if there was such a condition as ME, I would be sure to have heard of it."
Oh dear.
Firstly, it's bloody arrogant and ignorant, but also, why on earth should he assume that because he's never met something, it can't exist? But that's the kind of negative attitude. If you're talking about a GP who says he doesn't accept NICE guidelines, that's actually, I'm not saying NICE guidelines are written in tablets of stone. They're not compulsory. They are guidelines. They say that they're apply to about 80% of a patient group, and they are not a substitute for clinical judgment. So everyone is entitled to conscientiously object if they wish to, but they should have reasons. And actually, most doctors are now, who are a bit scared of everything, are a bit scared of being said that they're behind the times or that they don't listen to NICE guidelines. And I was criticised for 15 years for not following NICE guidelines because the previous NICE guidelines were wrong. They're never omniscient. The fact they can be wrong one year and right the next is just part of life.
I'm just cognizant of time there, Doctor. Just a few things that you sort of close up with is, if people have a diagnosis of ME, what other conditions should they be getting diagnosis for? Because obviously we know like a lot of people also have POTS, and also just to give people some confidence that when they are going to their GPs and sort of challenging them and asking for better care, is like, what is the very basic symptom management that all GPs should be able to do?
As you all know, pain is one of the worst problems. Myalgia, we can call it, and the headaches. The sleep can be a major problem. And symptomatic, well, I often teach that you should try to nibble around the edges and look for things you can treat. Quite commonly, you find that the headaches they're blaming on their ME are actually migraine, and you can actually help with the migraine with either diet or medication. The pain can often respond to treatments like amitriptyline. I've got quite a lot of patients do very well on amitriptyline, and GPs are perfectly happy to prescribe that for all sorts of other neuropathic pain. Sleep is terribly important, and whatever you do, don't listen to people who prescribe sleep hygiene. Sleep hygiene is as dangerous as graded exercise. There was a girl in the Southwest who had severe sleep reversal, and she slept from 4 a.m. to 4 p.m. And the pediatrician said she had to be admitted for a month of sleep hygiene. And she was admitted because they thought this was a good idea. But sleep hygiene for her was waking her at 8 a.m. and not allowing her more than 8 hours sleep in 24 and not allowing her any naps. She walked into that hospital and was carried out tube fed. And when the parents remonstrated, the pediatrician said, "I can assure you I took advice from the best sleep experts in the country." Yes, but not the sleep experts for ME. Never say wake up a patient with severe ME. But if you can actually improve the quality of sleep, improve the headaches. I mean, quite a lot of kids have recurrent sore throats, and you put them on a prophylactic antibiotic for 6 months, can make a major, all these little things you can do, nibble around the edges. The other thing, of course, apart from graded exercise being prescribed by doctors, most patients with mild to moderate ME are deciding on how much they do. And if they're attending school, they're going to make an effort to go to school because they don't want to get behind. And I saw 12 families in one weekend in Devon, all of that variety. At the end of the weekend, I looked at the advice I'd given, and in 11 of those families, I told them they were doing too much and they'd have to make their ME the priority and put education on the back burner. So sometimes it needs a third party to tell the patient they're doing too much. You all know the self-imposed pressure on wanting to get better and pushing it. And you all know a lot of adult patients all regretting not having had the right advice when they were younger. Can I just say one quick thing about long COVID? Long COVID is a massive problem. The government is treating it with as much disbelief as it would like to treat ME. And I think the two groups should make common cause. And I actually advise the long COVID group to, if they've got the version of long COVID that is like ME with post-exertional malaise, and I tell them to go for long COVID ME rather than long COVID. And then they have the protection of nice guidelines from graded exercise, because all the graded exercise and CBT merchants are now, of course, looking for other avenues, and their academic careers are almost destroyed, and they are all going to start doing research on CBT and graded exercise for long COVID. And of course, they won't call it graded exercise, they'll call it activity management.
Mm-hmm. Sorry, just a question there, come in. What's your opinion on the use of low dose naltrexone as treatment?
Apparently it can be really good for pain and energy, yes. And I know an NHS consultant who's just been disciplined for prescribing it for her long COVID patients.
And it's like everything.
There's a terrible sort of puritanism. It's almost like a Spanish Inquisition, that you mustn't do anything slightly unorthodox. In fact, the best doctors are always trying things for their patients.
And just another one come in. I firmly believe generalists are the best placed to diagnose and manage ME. It is too complex for specialists who could also be considered partist or single organ system doctors.
Absolutely.
I have made the diagnosis of ME in numerous patients who have already been seeing multiple specialists over the years, obviously.
Yeah.
It's quite a wee long thing here. I'm trying to move it up. Sorry for this. There we are. Who all diagnose an individual illness in their organ systems, fear of knowledge, or told the patient they couldn't find anything wrong with them and send them away.
I entirely agree. And the single organ specialists, who are actually proper specialists who only do their single organ, are not the best people for this. But the trouble is, in DGHs, there's increased specialization, and more of them say they forget the fact they're supposed to be generalists as well. So their general skills wither, and they say, no, they elect themselves as super specialists. Abraham Verghese, the author of Cutting for Stone, lectured Edinburgh students on a TED talk, which I recommend. He said, we're rearing doctors in America today who can't tell that a patient only has one leg without a whole body CT scan and an orthopedic consult.
Just before we let you go there, Doctor, I know that you have a long COVID conference coming up, but could you also let those listening know where they can hear from you, and if you have any other events coming up?
I don't think I have. There's one in Finland, which is rather like the one in Dublin, which I've been invited to in September. Oh, there's an all-day conference on FII run by the opponents of FII, the social workers and the psychologists who have seen the light. And I don't have the date of it to hand, but if you remind me, I'll send it to you.
Yeah, that would be great.
Perfect. I really appreciate your time. Is there anything you would like to add before?
Again, best wishes and apologies. And I'm always happy to talk to people on the phone. And a lot of what I do is not actually taking cases on, but directing people. And sometimes the most practical advice I can give is to change doctors. Just don't complain, don't provoke. Just say, could I see someone else? And and even change social workers. The last case I had, the third social worker got it right, the first two hadn't. So just gentle, diplomatic, tactical approaches.
Perfect.
Good. Well, thanks very much and good luck. Can I go now?
Yep. Thank you.
You can obliterate me if you like, or I can. How do I? Oh, leave. I can leave. Yes.
Yeah.
Oh my goodness. Thank you, Joe. Thank you.
Before everyone else heads off, we're hosting a number of events around ME Awareness Day in May. Obviously, I know I just want to touch on some of those. One of them is with Dr. Charles Shepherd. He's the honorary medical advisor of the ME Association. It's going to be an event much like tonight. If you haven't registered, go to our Facebook and do register. He will be speaking about a whole range of issues, and he's been working with us sort of behind the scenes and giving us advice on lobbying and sort of guidance around that. We also have events come up in Stormont and the City Hall. A lot of these are sort of private engagements, but we're meeting with our MLAs and other friends on the health committee, as well as other MLAs. We've been lobbying them for a long time, but in recent months, we've been very encouraged by the amount of traction we're getting from our MLAs. I also want to highlight one of our events. So in Black Mountain Share Space, that's in Belfast, Siobhan, along with our members Sarah Rose and Sarah, will be speaking about their experience with ME. For those of you that don't know, Siobhan is one of our members. She has been for years, and she's medically retired from teaching during ME, but she recently became a Belfast City councillor. So she is really the only elected representative that we know with ME, and we're also delighted to say she's one of our trustees. So it's because of Siobhan we've been able to engage a lot on the lobbying end of things. So that Black Mountain event with Siobhan and others is on the 9th of May. It's a Friday at 1. We're delighted to say there's about 5 political parties going and dozens of different charities and campaign groups. We're starting off those events at Stormont, and we're ending them in the City Hall, which is being lit up blue to raise awareness. Again, thanks to Siobhan, and we'll be meeting with a large number of councillors and possibly the mayor, depending on scheduling. So we're starting in Stormont. When we're finishing in the City Hall, I will send you all email updates about the types of things that we're doing if you would like to attend. And besides the awareness stuff, if you're in Northern Ireland, we host monthly peer-to-peer support and advice sessions that are on Zoom. There's usually about 20 or 30 people who attend every month. We have wellness days, including hydrotherapy and other types of complementary therapies like that. And we provide a whole range of signposting and advice, particularly around benefits, employment, and education. So if you're in Northern Ireland, please do reach out for more information, and also sort of just be aware that, like, as an organization, M.E Support, we're all volunteers. So we will get back to you eventually, but sometimes we just don't have the capacity. So beyond that, I want to say a massive thank you to Dr. Speight for everything he's done for us as a family. He would have met us 10, 15 years ago when I first took ill, as well as his support for people with ME. So I really appreciate you all attending, and do register for the Charles Shepherd event on the 6th of May. Thank you.